My name is Dr. Qamar Ali, and thank you for participating today webinar. And I'm a graduate from Nishta Medical College. And afterwards, I have worked in Fatma Memorial Hospital, Nishta Hospital, and Allied Hospital, Faisalabad, Saudi Arabia, Ireland, and lately King's College London. Today, I will try to review different types of jaundice and important differentials at different stages we have to consider while investigating and managing the newborn babies. I also wanted to highlight that even during this period of COVID pandemic, we still need to keep in our eyes, we need to be on toes as a physician, not to miss that early diagnosis can be made that usually make gross difference in the outcome of the child condition. I will little bit make light on the complication and management of these conditions. So going back to the medical college, as we know that the bilirubin is produced after the breakdown of red blood cells. And as we all know, and the basis is that the red blood cells being broken and bilirubin is formed, and that will be converted into different forms in the spleen, will be taken to the liver, will be processed in the liver from toxic to the non-toxic form. Some of part of it will be excreted in the urine. Major chunk will go after processing by the biliary system into the gut. Little fraction will be reabsorbed, major portion will be excreted. So this is the basic. And if we can see that there is a reason for the disease in the blockade anywhere in this process. But let me explain to you a little bit more easier way. So as we said that heme will come after the breakdown of red blood cells that will be taken by the spleen. In the presence of heme oxygenase enzyme, it will be converted into biliverdin. And this heme oxygenase enzyme is induced, as we know, with the hypothermia, hypoxia, acidosis, infection, as we can see in the neonates or in the prematures, that we see like increased jaundice. And that in the spleen again, with the help of bilirubin reductase, biliverdin, is converted into bilirubin. This bilirubin is then bound with the albumin, taken in the blood, transported in the blood from the spleen to the liver. While entering into the liver, help of albumin is finished, it will be bound with ligendin. Here, we have to see again, you know that in the newborn babies, especially the preterm babies, septic babies, they will have hypoalbuminemia. So they will be having more tendency or increased jaundice. So here we can understand the reason of hyperbilirubinemia in these newborn babies. Again, this ligendin that bind with the bilirubin is at very low level in the first 5 days of the life. So that is the reason of physiological jaundice. So then this bilirubin is entered into the liver and the function of the lesion is finished. Entering into the hepatocyte in the liver cells, this bilirubin with the help of the enzyme UDPGT, uridine diphosphate gluconyl transferase, is converted into conjugated non-toxic form. So here we have again few things that we can learn, that this enzyme is only 0.1% when the baby is born, to the adult value. And decreased enzyme is the reason of hyperbilirubinemia in the newborns. Again, staying here, deficiency or complete absence of this enzyme is the reason of Crigler-Najjar syndrome. We know that type 1 and type 2. Again, the abnormality of this enzyme is the reason of Gilbert disease that we usually come across, basically more benign form of hyperbilirubinemia. So after conjugation, this process is continued. This conjugated bilirubin is taken out of the liver through the biliary system. And as we know from our medical school knowledge, this biliary tract is open into the second part of the intestine, and that the bile is excreted there. So stopping here, again, we can see that this biliary tract is a tubular structure system, and blockade of this will cause increase in the bilirubin, as we can go back and see that there will be increase conjugated hyperbilirubinemia. So if there is any pathology around this tract of biliary tract here, will be the reason of conjugated obstructive type of jaundice. So it will make us understand the pathogenesis and the background of the different stages and the types of the disease in this course. After entering into the intestine, this conjugated bilirubin should have passed out of the gut. This is the normal. However, still a little bit more normal is that there is one thing that is called enterohepatic circulation. This enterohepatic circulation, again, it need this bilirubin to be in a non-conjugated form. And if we see this enzyme beta-glucuronidase that is present in the intestine, it will help in conversion of the conjugated bilirubin into unconjugated bilirubin. That will further enter into the system again to increase the bilirubin level again. So if we stop here again, we can see and understand this beta-glucuronidase, this enzyme is present in the breast milk. So this is the reason of breast milk jaundice. However, people dealing with the newborn babies, seeing the condition of, decreased gut motility, decreased feeding. So here we can see that decrease, the passage of the stool. So more stool is staying there, and it will also help in the conversion of the bilirubin with the help of this enzyme to the unconjugated, and then later on enterohepatic circulation and increased bilirubin. So with this flow, we understood at least few types of hyperbilirubinemia, either unconjugated or conjugated. If somebody asks the medical student, what type of hyperbilirubinemia is dangerous? I know most of you will say is unconjugated hyperbilirubinemia. That's why we need to be on our toes again, knowing that all the jaundice are not physiological jaundice. And the jaundice happening in the very early stages, like within 24 hours, is always pathological. So sometimes disease will not read the book. So we will not take it. The jaundice appearing in second or third day is not a pathological jaundice. One of my professor given as an example and saying that when you hear the noise of the hoof, always think of horses, not zebras. So coming to a little bit more schematic way of discussion of two different types of the jaundice. So as I said that unconjugated hyperbilirubinemia, most of the time we consider physiological, breast milk. However, we have to exclude the pathological cause, hemolysis, RH or ABO incompatibility or minor group incompatibility, and also see the associated factors like sepsis, some endocrine cause, or the enzyme defects, as I said, Crigler-Najjar or Gilbert. So let me share with you an example of the discussion that I had. In some part of the world, there are prolonged jaundice clinic. That jaundice clinics are sometimes led by the midwives and the nurses. And I received a call while being on call, that 9 days old baby, and she said, oh, baby is clinically very well, doctor. And I was covering the bleep for the hepatology, pediatric hepatology. And she said that bilirubin in milligram, it is 31, and it was 570 micromole. And so mainly it is unconjugated. So she called me and I said, have you contacted your neonatology team? She said, oh, it's very high, it's Kriegler Najjar. I said, please go back again and speak to your neonatology team, on-call team, because again, this is 9 days old, common is common, and this is most likely RH or ABO incompatibility. This is unconjugated hyperbilirubinemia. This is the entity of neonatology. This baby need urgent phototherapy, immunoglobulin, or exchange transfusion. And once the baby is being managed and investigated, you need our help, we can help you. So coming back again, so as we see in this case, any baby with the jaundice in the initial few days, we have to make sure, is there any evidence of hemolysis? If you see that there is evidence of hemolysis, then what you will do? You will see the blood group of mother, you will check the blood group of the baby, you will do direct Coombs test. You will also keep in your mind that could be sometimes red cell membrane defects or enzyme defects, could also be reason of disproportionate or very high level in the absence of positive test showing RH or AB incompatibility. So if there is no evidence of hemolysis, then what you will do? Then you will, again, we have to have holistic picture in the management of the child. So what you will do, that you will see, definitely always keep in your mind, infection is the most likely reason of jaundice in the newborn babies. So you do the infection screening. You see if there is any possibility of viral infection. You also keep in your mind some endocrinological or other conditions, as I mentioned before, like enzymes, Kriegler Najjar or Gilbert could also be the reason. So let me quickly summarize again, up to this point, what we have done. That the jaundice in less than 2 weeks old, we will see the split of the bilirubin, whether it is unconjugated or conjugated. Conjugated, we will discuss. Unconjugated, what we did. If it is in a less proportion, we consider, oh, it could be physiological jaundice. However, we have to exclude hemolysis causes, sepsis, or the endocrine cause. And then we will treat accordingly. Most of the time, we give phototherapy, reassurance of the family, or the general care, or general advice, symptomatic management. However, if you have excluded all these conditions and hyperbilirubinemia is out of the proportion, very high, then you consider underlying genetic conditions like Kriegler Najjar. And the treatment of those conditions in the beginning, again, is the same as we do in RH incompatibility or high hyperbilirubinemia to avoid the complication we know that kernicterus. So after finishing this unconjugated hyperbilirubinemia, I have not gone into detail of the management, keeping in my mind that our neonatology colleagues, they are doing their best in the management of these babies, and then referring to us once they are excluded and manage the primary situation of the child. So coming to the conjugated hyperbilirubinemia, again, we have to have most important clinical clue in differentiating, again, the different types of this variant to see the color of the stool. If the color of the stool is pale, unless proved otherwise, we always think of biliary atresia. We investigate in a timely fashion to try to get the positive and good outcome in the management of these children. However, there are other types like colorectal malformation, and inspissated bile that we will discuss in our coming slides. And then I will just, from my medical students and the nursing staff being participant in this webinar, that how and when we label a prolonged jaundice. In a nutshell, that if there is a more than 2 weeks in a term and more than 3 weeks in a preterm, baby is still jaundice, we say that is a prolonged jaundice. When there is a prolonged jaundice, we are worried of conjugated jaundice, conjugated hyperbilirubinemia. And when we say that it is a conjugated hyperbilirubinemia, roughly speaking, 1.5 to 2 milligram, if there is a conjugated fraction of the total bilirubin, or more than 20% of the overall total bilirubin is a conjugated fraction, we say that it is a conjugated type of prolonged jaundice that need evaluation in consideration to make sure that we can identify the treatable cause that could lead to the benefit in the management of the babies. So what we learned that jaundice is, and one thing I can mention that the urobilinism will pass, as I have mentioned in the very first slide. So you will see the dark urine, and that you will see the pale stool, clay color stool or not. So as I mentioned, conjugated hyperbilirubinemia will be further subclassified according to the color of the stool. So if there is a pale stool, so that is important to intervene in a timely fashion, like to make sure that we are not missing important diagnosis. Again, let me share with you another example that 4 weeks old baby has been referred by the GP because of the concerns of mother that child is yellow looking, baby is jaundiced. So if we have interactive session, I would have asked medical students or registrars a question that could be interesting to ask what you will see, what first thing or only thing that you will see that you will try or you will definitely ask the color of the stool from the mother. Or again, you have to have yourself look at the stool. Looking at the stool is not always easy. Sometimes you could have different colors in the stool. So there is a stool card available that sometimes help because again, it is not mathematics 2 + 2 = 4. You will see the different range of the color of the stool. Here in this stool card, you can see that in the upper 3, these are the abnormal stools. And when there is a yellowish tinge, this is an abnormal. This is the normal color of the stool. This you can see in the nappy. So what you will do at this time? Definitely you will examine the baby. Overall, you will see if there is any dysmorphic features. You will take the history. You will take the family history, birth history, antenatal history. And after examining and taking history of the child, you will do the baseline investigations. Here again, in the baseline investigations, as I mentioned earlier, in case of even unconjugated hyperbilirubinemia, that portion or chunk of the investigations will still be the part of the management. You will do that along with liver functions and INR. So while seeing such a baby and doing investigation and examining this baby, what is your plan? What is your goal? So your goal is to diagnose any treatable medical cause that could be life-threatening, or to identify a disorder that could be requiring surgical intervention in appropriate time that will lead to a very good outcome. And also you have to have in this your mind that there are a few conditions that mimic, and you have to avoid surgical intervention in such conditions or the diseases of the children. So let me share with you again another example of the investigations of the same baby here. So bilirubin is 203 micromoles. So it is around, I suppose, 12 milligram. And major chunk or portion of this hyperbilirubinemia is conjugated. See the ALT and AST, they are raised along with gamma GT, and prothrombin time is normal, and albumin is also normal. So with this picture of this 4 weeks old baby, definitely I will ask, what is the differential? What is the condition coming in your mind seeing such a baby? So I will answer again myself that it will be, you will have this for the medical students, nurses. I will give a suggestion of keeping their mind, they have to think of biliary atresia first. However, coming to our residents and the senior colleagues, we liver people sometime or most of the time also start thinking with the classification based on a gamma GT, that is going to be high GGT cholestasis or low GGT cholestasis. In high GGT cholestasis, biliary atresia is one of them, along with other conditions. And in the low GGT cholestasis, we have some syndromes that run in the families. So if in the same child, I will ask, what single test you will rely the most to assess the condition of the child among these 5 tests? I will answer the clotting, INR. This is important. Then I will ask, what 3 tests among these 5 tests you will prefer to investigate such a baby? I will myself answer again. That is ultrasound, HIDA scan, and the liver biopsy plus minus. So if you do the ultrasound, here you can see this is the shadow of the gallbladder. This you can see that it's definitely not a normal looking gallbladder. And the picture that I have mentioned in the previous, plus this ultrasound, one should think of biliary atresia. This is another sign that is called triangular cord sign in the ultrasound. Is also sensitive to diagnose. However, it is not specific, but it will help in making final impression about the diagnosis. So here I have just put this photograph. If you see, this is the normal gallbladder, and this is the abnormal post-feed contracted gallbladder. So coming to the HIDA scan, if you see, this is a radionucleotide excretion scan. There are some preliminary requests to do this test. Is sometimes we give enzyme inducers to help in the increased absorption of the dye. So if you see all the scans, you can see only the black image in the liver area, and there is no excretion of the dye in the intestine or the gut. However, you can see the kidneys and the bladder, but you can't see any sign of excretion of the dye in the gut. So this is another, you can see that in this scan again, dye has been absorbed only by the liver and there is no excretion. So this is the liver biopsy of typical biliary atresia. So if you see this blue, this is the fibrous, and here you can see this is a duct proliferation. And these are the features of biliary atresia on the biopsy that include bile duct proliferation, fibrosis, and portal tract expansion with inflammatory cells, portal to portal fibrosis. So what we are saying, that if there is a pale stool in a baby with jaundice who is more than 2 weeks old, we will take it as a biliary atresia. We have to investigate to rule in and rule out, although we will keep our eyes open to consider this long list of differentials with some important set of investigations, interpretation of the results, that can lead us to help us to start specific treatment in these conditions. So that case that is being discussed was proven biliary atresia, had Kasai procedure, 6 weeks of age, had a good bile flow established. We continued with the nutrition, vitamin, and prophylaxis of cholangitis in the management of that baby. However, on the follow-up of this baby, he took 4 or 5 months to normalize his bilirubin from 7 milligram to 0.5 milligram. And then later on, in the part or the course of the illness, he had 3 episodes when his bilirubin was raised. So that 3 episodes followed by, again, another few normal readings is showing that he had episodes of cholangitis. That is a proven complication or infection that we usually follow these children during the course of illness. So let me discuss with you, this case that I have discussed with you. We can see that a little bit quick summary is hyperbilirubinemia, blood labs, typical suggestive of biliary atresia. Although the liver biopsy was done, that was suggestive. HIDA scan was suggestive. Ultrasound was suggestive. Kasai was done in a timely manner. And child bilirubin and enzyme levels has come down and was being followed, had a course of cholangitis. But I have another case for you. In this case, again, 6 weeks old female with normal birth weight, normal baseline test, including endocrine test, thyroid, urine for reducing substance, and then the bilirubin enzyme levels, typical suggestive of conjugated hyperbilirubinemia. And INR was prolonged, that was corrected after vitamin K. So this child was presented, and then he was followed, as I mentioned in the previous slide. In the beginning, the ultrasound scan has showed gallbladder. And in the beginning, mother mentioned that the stool was pigmented. And the liver biopsy was tried and it was unfortunately not successful. And as you can see that in the beginning, there was coagulopathy. So there was a little bit reluctance also in doing the liver biopsy. However, it was done after the correction of INR, but that was not successful. And then he was discharged after sending some, the lab investigations that include gene panel, thinking of other type of cholestasis possibility. Then the child was seen in the clinic and he was passing typical clay white stool, and there was a conjugated hyperbilirubinemia and the level was further ranged. So all the investigations, they were tried before, then the plan was to do the ERCP. And then the ERCP was done, and that had shown there was gallbladder, there was slender duct was seen to communicate with the gallbladder, and there was a cystic duct or the common bile duct, but there was no filling above the level of the gallbladder. So that there was intrahepatic bile ducts were not seen. So that could be type 2A biliary atresia or type 3, when there you can see the gallbladder, but there was intrahepatic bile ducts were obliterated. So message and the learning point from this case was that, again, it is not always straightforward and simple that if there is a gallbladder, it is not always 100% that the biliary atresia is outruled. So for that reason, sometimes we have to have other modalities like ERCP and also the intraoperative cholangiogram to confirm the diagnosis and proceed further. So another case I wanted to share with you is the 3-month-old child. Was initially, mother consulted with the doctors that her child is having jaundice. Some baseline investigations were done. Mother was reassured. Stool was intermittent in the beginning, as I mentioned. And then later on, when the mother came, it was a clay colored stool, baby was jaundice, dark colored urine, and it was already 3-month-old child. So on examination, the baby was icterus, there was no dysmorphic features. Although there were no features of chronic liver disease, child was neck holding, there was no dysmorphic feature, as I said, and there was no other features. Otherwise, child was playful, active. So, and other findings, liver was 5 centimeter and spleen was palpable. Ultrasound was done that showed hepatosplenomegaly with mild ascites and contracted gallbladder. And liver biopsy was suggestive of biliary atresia. Now, 3-month-old child with this picture, what to do? Now, this child has missed the boat. Only option in the management of this child is a liver transplant. So, although Kasai procedure is a bridge to transplant, but we have seen, and the data show that children with a successful Kasai can live a life up to 1 decade, 2 decades without a requirement of the liver transplant. So this cholestasis is actually a Pandora box. And we have to open this Pandora box in a stepwise manner. Otherwise, it will be just fishing the diagnosis. However, if we go the way I am discussing, at least we can outrule the important initial conditions to make sure that we are not missing. So these are basically all the liver diseases, that infections, some transport defects, metabolic diseases, and also the Down syndrome, TPN related, and endocrine causes. This is one of the, you can see that is from the King's College Hospital. Data is that, is a published one, that the different variants of cholestasis, the idiopathic neonatal hepatitis and biliary atresia, the percentage. And if we can see that idiopathic neonatal hepatitis and extrahepatic biliary atresia is in the upper range and all others are in the less proportion. So let me make again quick summary of the few 2-3 cases that we have discussed in context of biliary atresia. So what we did, we have seen conjugated hyperbilirubinemia. We have seen it's a pale color stool, and we have seen this is a more than 2 weeks, 3 weeks old baby. So then we have started investigating biliary atresia. And then you will see, you will get the help of the HIDA scan. You will do the ultrasound, see the small gallbladder, or you will see the cyst. If you see the small bladder and HIDA scan is suggestive, then you can go straight away, plus minus with operative cholangiogram to do the Kasai procedure. However, if there is a cyst that you can make a diagnosis of colorectal cyst, that will end up in a portoenterostomy. If the color of the stool is pigmented or the normal color stool, then you can further subclassify according to the gamma GT, as I mentioned in the beginning, the high and the low, and then you can further proceed. So let me have a quick review on the biliary atresia. That is a disease, it's a scarring disease of bile ducts inside the liver, and it can lead to the complete blockade in the first few months of life. It can start early, even antenatally. So it is around 15,000, 14,000, one case in birth. Sometimes it is associated with other abnormalities like polysplenia, AST, VST, and intestine underlying malnutrition. In biliary atresia, basically there's a destruction of extrahepatic and intrahepatic ducts that can lead to the cholestasis, followed by fibrosis, followed by cirrhosis, and end-stage liver disease, as we have discussed already. So that you can see in the different investigations in ultrasound, HIDA scan, biopsy, ERCP, and on-table cholangiogram. So these are the different types, as I mentioned, by giving you an example of the case, that the different types that can dodge us a little bit in the beginning. So time is very important. If less than 2 months, if you operate, some studies say that there's a 90% chance of the clearance of the jaundice. However, this percentage will come down further if the procedure is delayed further. So this is one of the, I have checked from the study there that has shown that if it's less than 60 days, it is multifactorial again. It depends upon, the ducts, the remnant ducts there, and also the timing, plus the surgeon who is doing the surgery for this procedure. Plus, there are other factors. All the factors are involved in the positive and good outcome of this procedure. This is the person who first time did this procedure. This is a Brooks and Y loop, actually the part of the intestine after resection of the porta hepatis is attached in the porta hepatis of the liver, and that is again connected with the intestine from here. So this is the Rux and Y loop connection for this Kasai procedure. So in the biliary atresia management, beside doing this, we usually give MCT-based milk formula, fat-soluble vitamins, and also we give prophylactic antibiotics. We get help from the ursodeoxycholic acid to get the resolution of the jaundice. Also, we give enzyme inducers, and steroids are also part of the treatment. And on top of this, you know that the family support, reassurance, you know, education, and being in touch with them and follow them remotely, even if needed, is required to get the positive and good outcome. So biliary atresia outcome, as I mentioned, it can lead to the cholangitis is also 50% in the first year. Later on, it can lead to portal hypertension, sometimes failed Kasai, jaundice will not be cleared, and these children will need transplant earlier. However, the successful Kasai and cholangitis severity of the liver disease at the Kasai, portal hypertension, and all these liver transplants are the correlated factors that are being followed. So what we are learning now that the leading cause of pediatric liver transplant is actually biliary atresia everywhere, most of the time. So let me just go other than now biliary atresia. This is the colorectal malformation. As I mentioned already, that in the ultrasound, you can see such type of the picture. And these are again, different variants of colorectal malformation. It can present with the fusiform or cystic dilatations, or only in the bile ducts, intrahepatic system also involvement. So there are different types. Again, this condition is being treated as a porenterostomy. So there is another condition that is called inspissated bile. It is again extrahepatic obstruction of the bile duct by the biliary sludge, but you can't see the some stones or anything. And the leading cause of this condition is a prematurity, sepsis, delayed enteral feeding, use of diuretics in the newborn babies, premature babies mainly. So you need to be aware of this condition as well. So I wanted to share with you one of the case that I have reported when I was working in Dublin with one of my professor, Naomi McCallan. And we had one baby newborn, Down syndrome, that has developed jaundice. So learning point from this case was that whenever you see a Down syndrome baby with the jaundice, you must consider or keep in your mind that these babies sometimes present with transient abnormal myelopoiesis, some malignancies, and they have more incidence of idiopathic neonatal hepatitis. So in this case, what we did, we have done extensive investigations to make sure it is, again, as I mentioned to you, that we have to outrule biliary atresia or other endocrine causes and to see whether it was not TAM. So then I followed this case. As you can see here, this is the graphic presentation of the total bilirubin and the direct bilirubin. And that has come down at 3 months of age. It was started on very early. It was less than 2 weeks it was started. So it was 3 months that he has completely resolved jaundice. And this was the enzymes. You can see that these enzymes were also raised. And you can see that AST was rising earlier than ALT. And then ALT took a little bit more time than AST to come down to normal in 3 months' time. So idiopathic neonatal hepatitis is an important differential in the prolonged jaundice babies that usually present with acolic stools. And they are low birth weight. They have normal liver exam, mild hepatomegaly with normal to firm consistency. They are usually male, and there are familial cases as well. If you do the HIDA scan, there will be impaired uptake of dye, and the biopsy will be different than the biliary atresia. With this bile ducts will be normal in this type of the babies with giant cell transformation you can see. So let me discuss with you another case. So this is a interesting case. This will be more with the postgraduates, and this is a neonatologist colleagues, those who are confronting with the babies, those who are very, preterm babies. So we can see here 26 weeker, now 9 weeks old. History of necrotizing enterocolitis, was on TPN until 6 weeks, had 2 episodes of sepsis, and there was vomiting, slow to start feeding, and the color of the stool was yellow. We did the labs, can see that the upper are normal, although there is a jaundice, 100 bilirubin total, and main junk is a conjugated. So this is a conjugated hyperbilirubinemia with normal INR. So what is this? Is it a biliary atresia? No, this is not a biliary atresia. It is most likely a multifactorial cholestasis. However, you will do definitely all the investigation to still make sure that it is not biliary atresia. It is basically multifactorial reason that often sick neonates, preterm, and delayed feeding. And nowadays, the TPN is now changing to SMOF that help in having the less side effects of the TPN cholestasis as well. Usually these children respond well to urso, and with the time, usually they dissolve. So another case I have come across was 13 days old baby with unconjugated hyperbilirubinemia with raised TSH. So that was hypothyroidism with hyperbilirubinemia, was given treatment thyroxine and improved. I will go a little bit quick now. I suppose time is coming to end for my point. So these are the endocrine causes, and then the infections. And in the infections, you can see that hepatitis HSV is the common cause of acute liver failure. However, we also keep in our mind of other causes of torch infections. This is another case I have reported that actually was a baby asked by the nurse to examine because of jaundice. While examining the baby, I have examined the baby head to toe and found a bruise that you can see here on this adrenal area. So that baby was having full term, it was a quick delivery, had adrenal hemorrhage. So if we go back, this is a unconjugated hyperbilirubinemia. Sometime, there is a bleed that can also lead to hyperbilirubinemia. So this is another example that when you are seeing a baby, you have to have a holistic look on the baby to see all other associated reasons. So this is up till now, I have discussed with you a babies, mainly they are well babies. However, sometime working in the neonatal unit, you will come across a newborn baby that is unwell, sick baby. Usually biliary atresia baby are not sick. As we have seen, they usually are presenting even up to 2 months, 3 months of age. So the sick babies, if they are having features suggestive of hyperbiliary cholestasis, jaundice, you think of sepsis, infection, metabolic disorders. And in these are the 4 major areas that you need to keep in your mind that could be viral, metabolic, immune-mediated, or hematological. So then galactosemia, tyrosinemia, some mitochondrial disease, and other conditions that you keep in your mind. So initial metabolic, this is the algorithm for the metabolic if you are considering that. And in the management of these babies, again, the resuscitation, make them glucose control, give vitamin K, start antiviral, and consult with the hepatology. So this is the baby 2 weeks old, and baby was not feeding well, irritable, had a blood in the nappy area. This was a second baby, normal pregnancy, and its skin was normal. Normal delivery, mother well, and no family history. So this is the picture. In this picture, if you see, again, the baseline platelets are low, and bilirubin is a conjugated hyperbilirubinemia. Enzymes are deranged with gamma GT in the lower side. Plus, there is a prolonged thrombin time. So INR is prolonged. So this baby, further investigation has shown ferritin is high, and there is a serology for HSV is negative. They did the lip biopsy that has shown this is the iron-laden cells. If you see the MRI, this is the pancreas. This is also laden with the iron. So this is something related to the iron. So that condition is a neonatal hemochromatosis. This is a late fetal or early neonatal loss. History there in such children with the raised ferritin, synthetic failure of the liver, cholestasis. Catch point in these children is sometime because this disease started antenatally, and their liver is already damaged a lot. You will see ALT, AST not to that extent in proportion as we see in other conditions with the raised bilirubin. And alpha-fetoprotein is high. They are usually systemic iron overload. And as you see that sometimes there's a lip biopsy or buccal biopsy to see the iron staining. Although it's not straightforward sometimes. If you see the newborn babies already sick, having transfusion, sometimes blood transfusions also lead to the iron load, and that can make difficult diagnosis. These children required IVIG, chelation, antioxidant cocktail, N-acetylcysteine, and ultimately these children need transplant as well. So this neonatal hemochromatosis is difficult to diagnose. However, we keep this in our mind as a differential in the sick newborn babies, and importance in diagnosing this baby is that for the medical students to understand this condition is just like Rh or AB incompatibility. This is an alloimmune disease. And in this disease, there are antibodies of the mother across the placenta, IgG antibodies, and damage the baby's hepatocytes. That further lead to the progression to this disease. If this disease is diagnosed in the subsequent pregnancy, IVIG to the mother starting from 14 weeks of gestation is indicated. When diagnosing these babies, lip biopsy, if it is negative, then to do the liver biopsy and see the C5b9 staining. And then that can lead to the confirmation of this diagnosis. If this lip biopsy is negative, if this liver biopsy stain of C5b9 is negative, then you need to consider other diagnosis. Sorry, I'm going a little bit fast, I suppose. So coming back again, we are discussing that conjugated hyperbilirubinemia. We have discussed pale one, now the pigmented one. This is the alpha-1 antitrypsin. I will not go. I know that this is a disease not common in our population. However, when I was working in Saudi Arabia, one of my consultants, he always do that. He said, we have to do the workup of cholestasis. Maybe this is the first case we are going to diagnose and report that. So I suppose I have been in touch with my colleagues in Pakistan. We have less likely such cases in Pakistan, but this is the most common metabolic cause and then leading to liver transplant in the Western world. So this also we need to keep in our mind that these children need to be, make sure that we are not diagnosing and having this condition. So there are a few cholestatic syndromes. Alagille syndrome for the medical students, very important and very interesting, that there are typical facies. They have pointed chin, they have deep set eyes, and prominent forehead, and they could have, in the liver biopsy, they could have bile duct paucity, they have butterfly vertebra, and then in the heart, they have pulmonary stenosis. So any jaundice baby with murmur, think of Alagille syndrome, because sometimes it's very difficult to differentiate the facial features in the beginning. So you need to keep this in your mind that either you are dealing with Alagille syndrome, because it is difficult to diagnose in the beginning, and early diagnosis make a difference and good outcome, because ultimately this is the genetic diagnosis of this condition, because when you diagnose, then you can follow them, give them fat soluble vitamins, and for the itching you can give some medicines that will help, and the outcome of this syndrome is again 50% of the time they have normal function test up to the adolescent. Later on they can also end up in an end-stage liver disease, portal hypertension, and intractable pruritus. This is another syndrome, is a PFIC. This is again, there are more types, but major 1, 2, 3 is a 1, 2, and 4, they're low GGT, and 3 is the high GGT cholestasis. And that also we should keep in our mind. In Pakistan, I have recently seen another case with the type 2, PFIC type 2, and these children again, there is some granular transport defects that are type 1 is basically lipid transport, and the BSEP is a bile acid transport defect, and the MDR, multi-drug resistance, lipid transport defect. So type 1, again, with the liver, they have involvement of the gut and also pancreatitis and the deafness. And again, this is the type 2 that are also associated with the cholestasis. They have many mutations. They will again present with the jaundice, pruritus, malabsorption, failure to thrive. They have high serum bile acids, low bile acid in the biliary system, and they also have sometimes presentation with the gallstones, and they can also lead to the cancer, hepatocellular carcinoma. I have seen one case, even transplant, they have developed antibodies, BSEP antibodies. So these are the conditions that can recur also. This is another third type that I have mentioned, that also presenting with pruritus and the jaundice, and usually they can also develop into liver failure. So this is actually, I have just put here to show you that this is a cholestasis gene panel, because in the beginning, when you are investigating and diagnosing the cholestasis, you will stuck when you have outruled biliatresia, you have outruled colorectal cyst and infection or endocrine or major important causes that overlaps usually support, and we can diagnose and exclude them. Then you are stuck. What is this type of cholestasis? Cholestasis gene panel is being done in the different part of the world that usually help in making the genetic diagnosis. So coming to what is going to happen in the cholestasis that will lead to, because of the functional impairment of the bile formation, at the level of hepatocytes, then the complication can happen because of the structural interference with the bile acid secretions from the small intrahepatic bile ducts, or the structural interference, as I have shown you in the beginning, with the excretion of the bile. So that will lead to the derangement of biochemical markers. Clinically, you will see the jaundice. You will see in the histopathology different conditions. Consequence of the cholestasis, you will see the liver damage. That will be bile acid associated secondary biliary cirrhosis, and this damage. And then in the biopsy, you can see the bile stain. In the management, you will see the medical management is a nutritional management. Treatment of pruritus is very important to make the life of the child easy, and also later complications being management. In the management, in the nutrition, you have to give the good calories diet, and you know the dietitian or the nutrition support is required, because we know that these fat-soluble vitamins deficiency lead to coagulopathy, bone disease, and neurological problems with vitamin E and vitamin A. So catch point of the INR is, as we have seen in the previous cases of discussion, if you are giving vitamin K and the INR is corrected, it's most likely it's the biliary atresia in the beginning catch point. If the vitamin K is given and INR is not improved, this child is having some liver failure. There could be some metabolic disease, tyrosinemia, hemochromatosis, or severe sepsis. So this is the treatment that I have mentioned to you, and these are the different drugs that we can give in the pruritus. That's the cholestyramine. It's very difficult to find here. I have tried for one of the child here, but you can give phenobarbital or sodioxycholic acid and rifampicin. There are some procedures not frequently being done in our setup, but they are also the sources of improvement in the condition of the children. Ultimate, the transplant, I know that transplant is not easy job. It is, again, you are changing the disease from one to the other, because they have to live with that, with the medication, with their complications and the complication of the procedures as well. The portal hypertension, you know that you have to manage with the fluids, blood products, and then some interventions as well. So I will conclude it that you have to distinguish conjugated from unconjugated. You need to know the red flag, that is the pale stool and abnormal INR. Early diagnosis of conjugated jaundice in infancy enables early medical and surgical management. Optimizing nutrition with high medium chain triglyceride, milk, and supplement of fat-soluble vitamin is essential. So I will conclude this conclusion again, that conjugated hyperbilirubinemia, if you are not able to diagnose and manage it, refer it to the center, to your tertiary care center, to the teaching government hospitals, so that they can investigate in a timely fashion to get the good outcome. So I will end my talk and saying thank you for listening me. I know I have gone a little bit quick in the end, trying to finish it in a time. And I'm really thankful for all the participants. I will welcome questions from the participants that I can answer. So this is the first question. Why was an ERCP not performed before the liver biopsy? So as you know that ERCP is not is a primary investigation tool for the diagnosis of biliary atresia, because as I mentioned to you, because in the ultrasound they have seen the gallbladder, and in the beginning, and again the management is not always going like you see the textbook way. So there are social factors, family factors, the consultant to consultant, when there are different people managing the children, is variable. So in the beginning, it was thought that this baby, gallbladder is visible. There was a little bit intermittent, this one pigmented stool. I remember even we asked the mother to bring the stool, and that stool was kept in the refrigerator, so to be shown to all the team. So that was the reason actually. And when it was found that when he came, he was having the pale stool, and then, it was suspicion, maybe it's not biliary atresia. So then the ERCP was done. So I will answer to the next question is, if a neonate has persistent physiological jaundice who is on breastfeeding, what could be done? No further increase, but persistent jaundice, feeding on demand. Yeah, this is very, very good. I think this is the most practical question you have asked. Thank you for asking this question. And I have practically seen, as I mentioned in my talk, when you have excluded, in the beginning, like hemolytic cause or other causes, important causes that need to be excluded, and you have excluded that, and the child is breastfed, playful, active, and the jaundice is persistently there. As I mentioned to you in the talk, that there are the factors that in the breast milk, there is pregnenolone, there is fatty acids, there is beta-glucuronidase, that will lead to increased enterohepatic circulation. That lead to unconjugated hyperbilirubinemia. And I have seen many times that if you ask the mother, please, breastfeeding is the best feeding. You are doing good job. And this is to encourage them and let them know that what you do, keep expressing the breast milk for one day or for few feeds, only give the top of feed, and then you will see the quick decline. And that will be the diagnosis also, the breast milk jaundice. So that is usually helpful. So you can ask the mother, keeping this in mind, that not to tell them that is something pathology. This is again is a normal. And you just to stop few feeds of the breastfeeding and then give the top up feed, and then you will see the decline in the jaundice. I hope it's answered the question. So TPN changed to what? You see that the TPN, traditionally they are the source of the fat, in the TPN is different. So there was omega-1 and SMOF. So now there is a SMOF is the best, the source of, and the better source of TPN. So that has led to decrease in the TPN-related cholestasis. So I don't know, you have to see your pharmacy, which type of the, fat they are using, whether it is omega-1 or whether it is a SMOF, because the SMOF, they have changed to, different types that is very helpful, and that is having less side effects than the traditional one. Coming to the next question is neonatal hemochromatosis. Can we say it? Oh, it's totally different. HLH and neonatal hemochromatosis. I haven't, because it was not possible to touch all the segments. HLH, if you are considering HLH in the newborn, you will think of familial HLH. In the familial HLH, you will see the baby will be in a, like it will be also very sick, like in neonatal hemochromatosis. These are two different entities. In HLH, presenting early in the life will be familial HLH, you will do the perforance, and then you have to do the genetic testings. So, it's very difficult to handle this condition. So if you want to understand HLH, like you see the secondary type of HLH, in which you have to see, this is actually a cytokine storm. This is your body response with some viral infection, because of some viral infection, underlying immunological problem, some malignancy, some rheumatological problem that can lead to, in that cases, you will see high ferritin. And in that condition, you will see, it's just like a macrophage activation syndrome. So, but this is a familial type. It's different than neonatal hemochromatosis. Then you have to review these two different entities separately. It's not the same. I hope answer this question as well. Steroids have a role in biliary atresia, as shown in one of the, yes, the center where I have worked, and because I have skipped that slide quickly, and that I can show you that they are giving steroids. There is a proper regime made. In the beginning, they are giving prednisolone and then followed by dexamethasone. And they have shown, I have to see the, the studies which they have mentioned that there is a very good outcome of the Kasai procedure being given steroids after the procedure. Coming to the next question, phototherapy is usually used as the mainstay of treatment in the practice that I have seen, if it is raising rather than investigating the phototherapy, doses are increased, that is double or triple phototherapy started. Are there any implication to that, or if standard practice according to international guideline? Phototherapy is usually, you see that it depends, like if phototherapy is very easy to start. If you have seen, and you follow the chart, you will see the algorithm, the chart according to the age of the child, like how many hours of the age, and then you plot that on the bilirubin. And again, the line is different if there is no risk factor or the risk factors. So then while starting the phototherapy, doing the septic workup, starting antibiotics, good hydration, you are investigating and you are making sure that what type of the condition is this. So that is the neonatologist usually help you that you will see, while if there is a bilirubin level and the age, you are considering that this level is above the phototherapy level and it is exchange transfusion level, and you have the modality available to do the exchange, you can do that. However, recently I have seen most of the time babies, they are responding well to IVIG and triple phototherapy, and then they are avoiding exchange transfusion. However, again, arranging IVIG if it is difficult and you have this exchange transfusion available, you have to proceed that. Because phototherapy, you need to continue even after the exchange transfusion because there will be rebound hyperbilirubinemia. So there is no, you can see that there are guidelines available for the phototherapy and this treatment for unconjugated hyperbilirubinemia. How common alpha-1 antitrypsin deficiency in Pakistan? Should it be the part of investigation? As I mentioned already in my talk that I have discussed with few of my colleagues in Pakistan also. It's not very common in Pakistan. However, there is a suspicion that we are missing this condition because maybe we are not investigating. So I suppose I couldn't find, and I have to see the data in Pakistan if there is any prevalence or incidence of alpha-1 antitrypsin. This is mainly a disease of the West. As I mentioned you in Saudi Arabia also, one of my consultants, he said that we never had. I don't know, up to now it's 7-8 years back. I don't know what is the condition there at the moment. How late is too late for palliative surgery in a child with biliary? You see that I have mentioned you there. Percentage have you seen up to 80% success if less than 2 months. 8 weeks, then it is 12 weeks and 16 weeks, then it is only 20%. So you know that as the time is passing, outcome is less. And again, that's why it is important not to miss such cases to have the good outcome. When and how should we screen for tyrosinemia, hemochromatosis, galactosemia? Yeah, you see that this is again is a question that when you are investigating a child, as I mentioned in my slide, you are investigating a sick child. That child is having INR derange, and that cholestatic jaundice in the beginning, even if you can see in the first few days. So then you will keep all these things in your mind, and you need to start working on these and sending investigations. What practically we used to do is that any cholestatic child, even is sick or not sick, the center where I have worked, we used to stop. Give them the progestamil milk or the lactose-free milk and sending the Gallipot till the Gallipot result, for the galactosemia is available. And then we will resume the normal feed and keep going with investigating the other condition. So then, as I mentioned to you in the beginning, that you have to see and you make your judgment call, which condition, family history, all the things you have to keep in your mind, and then you have to investigate. But you need to keep this in your mind when you are dealing with a sick baby with the more derange liver function, synthetic function problems in the newborn babies. Sir, can we keep breastfed jaundice in differential first week of life as differential diagnosis? You see, Dr. Sania, there is two things. Is a breast milk jaundice, breastfeeding jaundice. So if you say the breastfeeding jaundice, yes, you will keep, because what does it mean? It means that your milk intake is less. You are giving less amount of the milk. And then again, gut motility is less. So again, enterohepatic circulation, decreased intake, all these sort of factors that lead to hyperbilirubinemia, as I mentioned to you in the beginning, that that's dehydration that will be initiating this was enzyme induction to increase conversion of the bilirubin. So yes, you're right, you can keep this in your mind, but again, this is very, very low in the list. Once you have seen that there is no infection, no sepsis, or no other factors that could be the reason of the jaundice. Any data of biliary atresia, patients got liver, any data of biliary atresia, patient got liver transplant, what's required weight for liver transplant for babies with biliary atresia? Thanks. Yeah, this is a huge question, I suppose, and this will be out of this discussion today. I was reviewing, and I have come across, I have actually shared the slide that of the biliary atresia followed by the liver transplant. Actually, I got one from India, and they have mentioned about their children of liver transplant after the biliary atresia and their outcomes. Again, this size of the liver transplant weight is actually the left lateral segment they usually give. So, it depends upon, monosegment also, but depends upon the weight of the baby when they are doing this transplant. Which babies are more likely to develop jaundice that need treatment? Which babies are more likely to develop jaundice that needs treatment? You see that this jaundice is very common, as we could see that most of the time physiological jaundice. So there is no treatment for physiological jaundice. And unless there is a proven condition that I have mentioned in my different cases, that you could see this is incompatibility, then you will see that you will give the phototherapy. Then later on, some hematologists say that you can give the folic acid to these babies being followed, and try to avoid the transfusions. And and then they're usually recovered, and you have to follow for a few months. And other conditions, breast milk jaundice, as somebody asked, I have mentioned about the treatment to just stop few feeds. And then if this is jaundice related to some syndrome causes, then is a long track. Then you need to follow them. Then you have to do the symptomatic management. You are not going to treat them. Basically, you have to do the symptomatic managements. So this depends upon the etiology and the age, and then follow-up causes of the children. I hope I have answered all the questions. And again, thank you for participating in this webinar. And I'm glad to see the attendees, and they have asked the questions. And my message is, even in the pandemic, we try not to miss the common causes that can be manageable, and at least to give some, the help of our newborn or over the younger generation. You all in this pandemic, stay safe and stay blessed. Thank you.